Hello, everybody. So energizing to see so many people interested in this important topic. Thank you so much for being here. So my name is Catherine Cheney. I'm the senior editor for special coverage at Devex, and for a long time now, I've covered this topic, technology and innovation in global health and development. While that's a cross-cutting beat that really cuts across the SDGs, the one space where there is so much potential, it seems, is digital health. But emphasis on the word potential. There are, of course, so many exciting applications of digital health, and I hope we can hear about those today. But there's also a huge gap between the innovation that's happening and access in the communities that could benefit most. So that's what we will be discussing today at this event, From Hype to Health, Digital Solutions That Deliver Value, hosted by Devex in partnership with Medtronic LABS. Without further ado, we're getting a bit of a late start because we had to get all these people who are so interested in this topic seated. I'm going to go ahead and kick things off and invite a couple of speakers to the stage to discuss advancing digital health in Africa. So first, I'd love to welcome Ruchika Singhal, president of Medtronic LABS. And let's give her a round of applause. Thank you. Feel free to take a seat here. And we're also joined by Jean-Philbert Sangimana, Chief Digital Health Advisor for the Africa Centers for Disease Control and Prevention, or the Africa CDC. Thank you both so much for being here. And Phil, it's nice to meet you in person. We've discussed these topics before virtually, so great to have you. So Ruchika, I wanted to ask you, today's focus is not just on digital health. We hear there are lots of sessions and conversations on digital health, but specifically the role of community-based solutions. And I really love that framing, and I want to better understand and help our audience understand, why is Medtronic LABS focused on that community element when we talk about digital health?
Absolutely. Thank you, everybody, for being here today. We have 8 billion people in the world. Majority of them do not have access to healthcare, and we're never going to build enough hospitals and clinics to take care of all of them. That's why community is important, because health is going to happen at the community level. And the only way we're going to get access at the community level, again, never going to have enough of a health workforce to be able to reach out to all of them, is through technology solutions. Mm-hmm. Hence, digital and community have to go together. We're also seeing the changing nature of diseases around. It used to be just infectious diseases, but now even in low middle income countries, chronic conditions are existing alongside and often worsening the existing infectious diseases. So with that, we can't also just have silos around single diseases, but really thinking about how do we create access to wellness and integrated healthcare at the community level is important, and technology plays a role in that. So that's why I would say community plus technology.
I love that. And just a follow-up question. I've asked all our speakers today to be prepared to talk about what this really looks like, because, we want to leave the room today understanding the potential and therefore being so frustrated by the fact that more communities don't get to realize that potential. So what does that look like? Like, what's an example you're excited about that you can tell us about? You have to be the glass half full kind of person to work in the space. Otherwise, it's very easy to get frustrated. But I would say, for us over the past few years, we've been experimenting with a lot of this. And what's so heartening to see is we know all the problems. We know about the supply chain issues, the lack of healthcare workforce, the bad roads, the bad internet connectivity. Despite all of that, right now, in the past 2 years, we're operating in about 5 countries in various locations, in rural parts, unreachable parts, and through the use of digital tools and working with public health systems, faith-based health systems, we've been able to reach about 180,000 patients living with chronic conditions that we're actively managing, and we're getting control rates for hypertension and diabetes north of 60%. Mm-hmm. And with the data that we're able to collect, we're actually able to do incremental improvements on that day by day, week by week, month by month. That kind of outcomes, historically, we were only able to do surveys once every 5 years that cost ridiculous amounts of money. With that kind of information, the power, once you start to scale that, it can be completely transformative. So all those challenges exist, but we're still seeing those results despite all those challenges. So I think you can overcome them. Thank you. I hope so. And we'll talk about how in today's conversations. So, Phil,
I know that, speaking of scale, your mandate is really to help the African continent and member states in the Africa CDC go through this digital transformation. And you have a digital transformation strategy to help them do that. So can you talk us through that? What is this digital transformation strategy? And how do you get from idea, a written strategy, to reality on the ground where these digital solutions are actually reaching communities? And what challenges stand in the way?
Yeah, I mean, it's difficult to share the stage with somebody from Medtronic because it happened to me twice. I had a point to make, and then she makes it take so much from my mouth.
Stole your
Because
thunder.
so aligned. But I think one of the challenges that she highlights is the fact that you've got all these experiences on the ground, things that work, controlling high blood pressure in a population by using a very nice tool. But then most of those experiments have remained where they were conducted. So we have pilotitis, which I think something that everybody knows. And I see our role as Africa CDC to try and help scaling those experiences. And the way you do that is, first of all, there has to be an awareness of what's working and what's not working. So from the launch of the strategy in March, we've formed partner working groups. So Medtronic is part of one around digitizing primary care. We want people to know. We want countries to know. We want other partners who are trying to solve the same problem to know that there is a solution, and we stop reinventing the wheel. And then once we are aligned about what works, we want to bring our convening capacity, our mandate as Africa CDC, to encourage and promote those solutions, encourage countries to take up those solutions. We want to see a continent whereby by 2030, everyone can be reached, everyone has access to healthcare, and we know it's not by building more hospitals and more health centers, it's by leveraging the single most distributed piece of infrastructure that the continent has, which is the mobile technology.
So you mentioned pilotitis, and that's something I definitely have come across a lot. I'm based in California, writing a lot about tech companies who want to deliver value in digital health, but often there is that problem that there's a pilot that doesn't go to scale, and the countries have to then deal with the consequences of that. The partner working groups framing is very interesting to me. So how do you kind of reframe that relationship where instead of an external partner coming in, launching a pilot, and then leaving, you're actually building a win-win relationship with external partners?
So there are two ways. Number one is once this solution best practice has been identified, what we are doing as Africa CDC is we are building something we call Africa CDC Data and Innovation Sandbox, which is a mechanism to really test that application. Test for policy compliance, for regulatory compliance, for data governance compliance, but also test for other things like scalability, sustainability. What's your business model? Some of these solutions coming from outside, they are not scalable because the cost of running those solutions is just not sustainable. So what is the role of the local health tech innovators? Kenya gave us M-Pesa. 10 years after, we've got 8 unicorns in Africa, and those are the only unicorns that we have on the continent in the fintech. What we really have to see is how do we start moving to having a health tech unicorn? And that means that is a solution that has scaled to take advantage of 1.4 billion people on the continent, and where people have come together to really support that local innovation. So I think the way we take the solution to scale is either through very scalable, private-driven innovations with a very good cost-effective business model, or through government adoption and also cross-border scaling of digital health innovations, which can only happen if institutions like Africa CDC step in to encourage and promote.
Thank you, Phil. Ruchika, I want to return to something you said earlier. You mentioned not only the infectious disease burden in Africa, but chronic illness. And with non-communicable diseases on the rise, I want to better understand when we talk about digital health solutions delivering value, how do you ensure that those digital health solutions are actually meeting the priorities of African governments rather than external partners coming in and saying, here's a digital health tool for X disease area. Instead, countries saying, well, these are our priorities, and increasingly NCDs are becoming a problem, and external partners supporting them in that.
Yeah. Well, so what I would say is there's a unique thing about chronic diseases which makes the challenge particularly hard, which is it's chronic. So once you have it, you need to manage those patients for a long period of time. And also, the management is complex. It's not as trivial as you take a pill. Even for a set period of time, you need to adjust. And which patients need what kind of intervention at what point of time needs to be adequately managed. That's where the digital tools can be transformative in optimizing outcomes for patients. So that is one thing. I almost think of digital 1.0 has been about digitizing paper-based data, aggregating that. The next version of this has to be how do you use that data to improve service delivery on the ground. One, for improving healthcare outcomes for patients, and second, for much more efficient healthcare delivery, because the resources are stretched, and we have to maximize the existing healthcare infrastructure that exists for efficiency, and digital enables that. In terms of working with governments on that, what I have been really positively, and this is the glass half full part, most of the government leaders we're engaging with on the continent understand that, have a vision for that, and we're shaping these solutions in partnership with them on the ground. So in a country where NCDs are part of number one, number two, the focus is on rolling those solutions out first. In countries where maybe there's literally nothing, no infrastructure, maternal child health rates are some of the worst in the world, we're starting with that as a priority. The fundamental concept still applies in terms of focusing on outcomes and efficient service delivery, leveraging technology, but what those priorities are have to be determined at the national level by engaging those national stakeholders. So that's where I think the partnership with you has been so awesome, because bringing together those stakeholders and really aligning with that, where it's not an external partner coming in, but we're really co-designing not just priorities, but the solution itself on the ground, because it all needs to be localized to a large extent.
I want to dig in on your point on data and get Phil's thought on this, because I like your framing that sort of a phase one and phase two, right? So digitizing paper-based products, and now it's using that data for better outcomes. But there are a lot of challenges that stand in the way. So Phil, when it comes to data, this data is often siloed. Patients lack access to their own health data. Often it's collected and they don't even know for what purpose or see the benefits necessarily. So how can countries ensure that data is protected, which is of course important, but also utilized? And how is the Africa CDC working on this challenge?
So I see two ways. Number one, my friend from Kenya who's going to come up on the stage told us that there is going to be a digital health bill that is going to go to Parliament. So one way of ensuring that the data is protected and that the people have access to their own data is making it mandatory. It's costly and it shifts value. This data today, even if there is not enough digital health data going around on the continent, but there is a good amount of data. And the first beneficiary of the information today is government. Governments have put up systems to collect data, and that has really gone a long way informing public health program design. But the second is the private sector. They are conducting massive surveys, and through the phones, they are accessing our health data with or without our permission, and they are extracting enormous amount of value without asking anyone's permission. The last and the least beneficiary, who should be the first, is the owner of the data. So the incentives for hospitals, pharmacies, labs to share data back to the people, currently I think they are not strong enough for those institutions to start doing it on purpose. But I think it's just a very short kind of vision. I think there's going to be a point where they will realize it's in their best interest to have customers who are informed, educated, and empowered. And at that level, the switch will happen automatically. But we're not going to wait. So things like making it mandatory, regulating the space, making sure that all those who hold people's data are protecting the information and they're sharing it back so that people can be making those decisions on their own. Even managing chronic diseases, the person should be the first to take, action on their own health, not wait until they've been reminded and so on and so forth. Because again, remember, we are a continent with a vast majority of people who are young, digitally native, so they can really make sense of that information and take better care of their own health. But the second way that value is realized is by using technologies like artificial intelligence. So we know that if we strip anything that is personally identifiable and we feed this data into AI engines, that can spur a lot of innovation, and there are a lot of young people on the continent who can design algorithms and programs. If this data was to be accessible, sort of become a public digital good, then it can go a long way, really helping us inform, public health interventions.
Thank you, Phil. We're about out of time, but I really quickly want to hear from the two of you on a final point. One thing that hasn't come up explicitly yet, and is of course critical, is investment. So final thoughts, literally a sentence if you can. What's a final call to action for anyone in this group who cares about advancing this space? And if you can tie it to investment, since we haven't adequately addressed that point, maybe we should talk about that. Very quickly, Ruchika.
Well, I would say we need a lot of investment, but we need smart investment in tools that are scalable, interoperable, so that we're building for the future and focus on the improving clinical outcomes for patients, and then also improving the efficiency of service delivery on the ground.
Thank you. Phil?
Investments from the private sector. Come and talk to our young innovators. There are so many who have investment-ready products and services, and also better investments, to your point, especially from the public sector. The only way, again, these pilots are going to scale, especially when the initial funding came from a philanthropy or an international NGO, is by the government saying, we love this. We are going to scale this up at national level.
Thank you, Phil. Please join me in thanking our panelists. Thank you both. Now I'm going to go ahead and welcome a few more experts to the stage, and we're going to narrow in on how we really break down these barriers for digital health systems. So you'll see our panelists in front of you here. I'd love to go ahead and welcome to the stage Dr. Omar Ishrak, former chairman and CEO of Medtronic. Yes, please take the stage. Dr. Patrick Amoth, who's the Acting Director General for Health in Kenya's Ministry of Health. Jerome Obereit, Executive Director of BRAC Global and former Secretary General at MSF. Great to have you. And finally, last but not least, Leisha McCormick, the CEO of Last Mile Health, which partners with African governments to train professionalized community health workers to deliver health services. We'll hear more about each of their models in just a moment. Thank you all so much for joining us. Please join me in welcoming our panelists first to start. So I want to begin by asking you all the same question, just to quickly hear from each of you. And what I'd love to hear is, when it comes to, before we talk about how to break down these barriers, let's understand what these barriers are. So just ever so quickly, what's the single biggest barrier you see to digital health realizing its potential, kind of building on the conversation we just had? And maybe through that, we'll get a sense of what your organization does. But maybe we'll start with Leisha. What is the single biggest barrier you see? And then we'll talk about how to tackle them.
So the figures of folks that lack access to healthcare continues to grow. I think when I was in rooms like this a year ago, we were quoting that there were about 2 billion people globally that lacked access to care. And now we're actually indicating that that's about half the world's population. So if we look at that group that is actually lacking access to care, we actually know that a pretty high percentage of them live in remote and rural geographies. And those folks that are lacking access to care, Catherine, are also the ones that are lacking access to digital technology. Mm-hmm. So in particular, women and girls that are living in remote rural areas are often facing a double bias around access to both healthcare access and digital and technologically enabled tools. And I think to really close that gap, we need to put the last mile first.
Put the last mile first. That's a great call to action to begin with. Go ahead, Jerome.
So thank you very much for the question and the invitation. I think one of the key barriers is to break down the non-recognition of the role of the frontline community health promoter, community health worker. To actually be able to reach numbers that have been pointed out by the colleagues on the panel previously and this one, we need to ensure that the role is recognized as not just a good to have and a voluntary role, but as really a formal role that actually fits into a continuum of care from the household, the community, upwards into the health system. Now, this means task shifting. But to do task shifting responsibly, we have to think of recognizing that role within a broader health system. So that recognition is key.
We'll definitely come back to both of you on the critical role of community health workers, because I know that's something you both work on closely. Dr. Patrick, let's hear from you. The biggest barrier you see.
Thank you for the invite. For me, I think the biggest barrier again is how we have deployed digital technology. We have tended to focus at the higher level of care and forgetting the foundation of any healthcare system, which is the community and the household level. So if we can be able to have a fundamental shift as to how we deploy technology, instead of focusing at the secondary and tertiary level of care, why don't you begin at the foundation where the community health promoters at the household level, because health eventually starts with me and you at the household level before we go to the facility. So if we can be able to have a strong fundamental base of the community health system that is digitally savvy, then definitely we can be able to hack it.
Thank you. And Omar, you've seen the potential. You come from the private sector, but what is the biggest barrier in terms of helping some of the countries who could benefit most see this potential?
I think, a lot has been said already, but in my view, one additional thing is the alignment of all the stakeholders. In the end, to get a positive result from a healthcare program, it's not just one entity. It's private entities, it's governmental entities and different departments within the government. Different kinds of technology. It's, digital health is a very broad kind of terminology. It has lots of things in it. And so to get all the stakeholders aligned and in many ways inspired and motivated by a vision of improving people's lives around the world, I think just getting that message across and aligning everybody is probably as big a barrier as anything.
And this is a good week to try and find that alignment. So let's hope we can. I want to start with a question for Dr. Patrick. So earlier, Phil mentioned Kenya's work to build legal frameworks, really, around digital health. So there's this digital health bill, there's your e-health strategy, and I wonder if you can expand on those and how they directly tackle this problem of barriers for digital health.
Thank you for that question. For us, the strategy is basically to be able to see how we can be able to move the bits and pieces of digital solutions that we have, especially in the vertical programs that exist. How can we be able to bring them under one common layer, interoperable layer? And our approach has been to do the reverse, focus more on the community level, and therefore we are prioritizing the use of digital health tools at the community level. We have what we call the electronic community health information system, which is used by the community health promoters, not only to be able to gather data on health, but also socioeconomic data for us to be able to develop a tariff band for the National Health Insurance Scheme, which is based on a social insurance approach. And from our discussions with our partners, digital solution makers, we have realized that even at that lowest level of healthcare delivery, you can actually be able to deploy digital tools. You can be able to repurpose or retool a community health promoter who has a basic level of education to be able to capture very, very important information that will lead to decision making. But because that is usually not anchored in law, we said, why don't we now, for us to be able to make this mandatory by passing a bill, and therefore we have developed what we call the Digital Health Bill, which will be discussed in Parliament to make it into law. Therefore, then we can be able to have one common ecosystem for the entire health delivery system in Kenya on a digital platform.
Thank you. I was talking with someone about what a great lineup we have, And someone was mentioning how great it is to include your perspective, because one path forward for digital health is to make it law, like build it into the law. So really interesting to hear more about how that's going in Kenya. I want to go to Leisha and Jerome, actually, because to the extent possible, I want to have a conversation here. And both of you, I know, believe so deeply in community health workers as being essential to the path forward in breaking down these barriers. So I'd love to hear from each of you on that. What are the biggest opportunities for community health workers in breaking down these barriers for digital health? But also, what are the biggest challenges? Maybe we'll start with Leisha.
Sure. So I really appreciated Jerome's comment around validating the role of community health workers and professionalizing them and making sure that they actually have the inputs that they require to be able to do their work effectively. And I think that we've seen, I was actually meeting with colleagues from Gavi just the other day, and we saw in Liberia where the government of Liberia has actually instituted a cadre of about 5,000 community health workers that have now seen not just one, but actually two pandemics of both Ebola, or I should say epidemics and pandemics, Ebola and then COVID. That those community health workers have been able to help the country get to 90% rate of immunization for COVID. That is a really big deal, and I think that that is happening because of the inputs that those health workers are receiving and because they've been considered valid as a cadre of health worker. I think the other thing that I would sort of touch on is that those inputs increasingly require technology. Radhika, when she was up here, actually mentioned that community and technology are actually two sides of the same coin. I think particularly when you're going to the community level, the notion that you're actually asking frontline practitioners to administer a wide array of tasks with a high degree of proficiency is going to be improved by technology. I would say one other thing that I have increasingly been conscious of, our colleagues from Lawala Community Alliance actually released a study about a week ago that showed that the sort of stated rate of education and literacy of community health workers is actually not indicative of their ability to acquire skills or to deliver quality care. It's actually indicative of prior privilege. So when we actually think about the potential and the opportunity that technology invites, the notion that we could actually develop and adapt tools that are appropriate for frontline providers that might be coming from lower rates of either literacy or digital literacy is just absolutely really very powerful for me.
Thank you. You want to build on that, Jerome?
Yes, and I mean, community health workers, all those involved in community health have had, we've been working with them for years, and their recognition, as we've mentioned, is key, but also as their roles are recognized, we've got to be clear about what task they will undertake. And so there's an issue of task shifting here, where we need to do that responsibly and in the right way. And really, to do it responsibly, you need to ensure you have a good monitoring system. You need to ensure you have a good continuous learning system, because I fully agree, the capacity is there, the talent is there. It's often an issue of having had the opportunity, the privilege to be able to learn, which is not there. Now, this is where, if we have the right information at the right time through connecting digital technology and through connecting health systems with digital technology and communities, we can ensure that there's an ability to monitor, but one of the most important things we've seen in our tens of thousands of community health workers, which are now digitally connected with tablets or phones, is the continuous learning they can do through the tablet. So it's not just about the delivering and doing the right kind of information towards the patient, but they can learn in their own time, at the right time. Before you'd have a community health worker, you'd have to actually go there, do the initial training, go and do a refresher course, and it might be the wrong course at the wrong time for the health worker, because actually they have a lot of other issues they need to deal with within their own community. Now it's the right training at the right time for the health worker, because actually through digital health, you can identify what are the areas that the community health worker is struggling with. What are the areas through a good monitoring system where we need to improve the training and maybe focus a little more. So the whole supervisory channel becomes a lot more efficient. And what's actually quite interesting in terms of the money question that was there earlier in donors, BRAC has actually saved millions in supervisory costs through actually connecting community health worker with tablets. So it's a very cost-efficient way of doing health business in a way. And it not only saves time in terms of community health workers spending more quality time with the community and those that need the health support, it saves money, and it also enables the scale to actually be at a completely different dimension. Now, the final point I want to make is actually to be able to ensure that there's trust in the community health worker, they need to have trust not only from the community, but also from the health system. And again, having the right kind of information at the right time, making the right decision, and being able to actually spend the dedicated time both with the patient but also with the health system actually enables that connectivity and that trust to be built over time.
Thank you. Yeah, it's a really exciting space. There's been a lot of interest in this term, digitally enabled community health workers, right? But speaking of going from potential to reality, we're starting to see what that really looks like, some really interesting use cases, and definitely a space we're following closely at Devex. I want to go to Omar. This has come up a little bit, and part of the momentum we're seeing in digital health is certainly due to COVID-19. I mean, the pandemic really fast-tracked a lot of digital health innovation, and I think the question now is which of those tools will last and really scale in low and middle income countries, and what are the challenges that stand in the way of that? So can you talk a little bit about the challenges, but also the potential you see of some lasting impact?
Well, a number of things. First, one of the things that COVID did do, there's a lot of debate and controversy about what works and what doesn't work, and whether whatever, I won't go into all of that, but one thing that everyone does agree on is that people who already had conditions were more susceptible to COVID than people who didn't. I think we could get universal agreement on that one subject.
Yeah, I think that's a
fact. And so that actually is an important statement. And it then, I think, encouraged different entities, governments as well as private companies looking at this space, to have the sense that chronic disease management, which is the core vulnerability that it creates in people, is an important element to manage in rural health. So that the visibility of the importance of chronic disease management, I think, came up. I don't know if it went all the way, but it certainly came up. It became visible. So that's one thing that happened. Yeah. The other thing that happened in COVID is what you mentioned, is this remote care, which I think some of it is being pulled back because you don't need it all that way. But what it did is forced both a desire for remote care and technology that was created to make it faster. Everything from Zoom calls to whatever, all these different things came up, and the technology grew very quickly, and it was in the general healthcare space because COVID was a healthcare problem. I think the third thing that it did is, in all the things that governments think about every day, health became a priority. Yeah. Because there's all kinds of other things, but health became a priority. So, if you look at those three things, how do we leverage it today? Certainly using technology to access more people in remote areas is the thing that's happened there. The remote management has happened. But I think the challenge there and the task that we have to face is how do you then take that visibility, take that technology and focus it on something that changes an outcome. And I think the general thinking is more towards building tools, which is important, but how do you apply the tools is very important, because at the end of the day, the other fact in healthcare is that every individual is different. One solution for everybody is not going to work. The healthcare systems in general divide people into cohorts, people with disease, without disease, serious disease, and so on. But in the end of the day, every individual is different. And so these outcomes and the focus has to be there. Pick a disease, work on it, move the needle, rather than I'm just going to build infrastructure, because that's not going to achieve the result. Pick a disease, work on it, and then do the two in parallel is the way I would think about it.
Any reactions to that first?
Yeah, I think that's right. There's, we need to ensure that it's adapted, and to do that, this is where at some point in the development of the tool, there has to be involvement of those that will use the tool, and it can't just be imposed as such, because as Omar has rightly said, there's not one magic wand that fits every community. So the involvement of women, the involvement of community, in the tool construction, and then in how they can own the information. And that's the next challenge, because if you just push the data up and it just becomes a kind of a conveyor belt of data, you lose actually all the added value you can have along the continuum of care that you can have. So from the household to the community worker to the primary healthcare structure upwards, this information is worth gold at each level and it's got to be recognized as such.
speaking of involvement, I want to go to Dr. Patrick on this question, which is essentially the role of government in communicating to citizens the value of digital health. You know, how do you handle this? Costs money, it takes time, and I mentioned earlier, sometimes people have health data collected and they don't actually see the benefits of that data because the system is broken. So as you are pushing through this legislation, what's the dialogue like with citizens about, you know, what's in it for them?
The dialogue is basically about taking the health to the people so that you own your own health, and working with the community health promoters who come from the same community as you, who are trusted, chosen by the same community. Then that dialogue becomes a little bit easy because it's part of the entire ecosystem. But what is important is also not only for the community to be able to use that data, but for the facilities in terms of their planning, because based on the data that is going to be collected from the household level in that particular community linked to a particular facility, they can be able to visualize what kind of healthcare problems they are dealing with. And in terms of their planning, then they can be able to sit down and prioritize the interventions that they are going to take going forward. And at the higher level of care, of course, that data, when it is aggregated then, and it is in sync with the Kenya Health Information System, then we can be able to visualize it at the national level to be able to inform policy decision. But I wanted also just to add at this particular juncture that as we do this task shifting, let's also not overburden the community healthcare workers. Let's give them what they can be able to handle, but also let's support them. For example, in Kenya, what we are trying to do, because some of the community health promoters have secondary level of education, we are giving them a bridge to be able to graduate when they go for a 2-year course at the Kenya Medical Training College. Then they can become certified healthcare workers who can then be able to move along the continuum of career progression. So it's very important as we do this, because these people are also going to collect a lot of data, that we provide them with the support, and during the review meetings in the consultative or community health dialogue days, then we can be able to visualize the data when we bring the entire community together in a kind of a meeting like this. In our place, we call it a baraza. So the community health worker or community health promoter with a community health assistant and the entire sub-county health management team will be able to sit down and look at their data. This is the burden of diarrheal diseases. These are the number of mothers who delivered at home, and therefore design interventions collectively to be able to improve their health. That is the space that we are trying to work into, basically empowering communities. And also along that digital health platform, then we'll also have a scorecard, working on a traffic light system, red, amber, and green. We'll track the indicators that are doing well, which are in green, the ones that require a little bit of motion in amber, and the ones which are definitely not doing well, red. And therefore, in terms of priority, then those becomes the number one interventions to be undertaken.
I want to bring Leisha into this. Dr. Patrick, you mentioned healthcare workers are overburdened, and that's certainly a problem among community health workers. We're often asking too much of them, so I think that's a big challenge. Another big challenge, I think, but I want to hear from Leisha on this, is interoperability. That's a term that came up earlier, but I kind of want to break that down. What do we really mean by the challenges of interoperability? So to frame this in a question, I think all too often when we think of community health workers and digital health, we might think like community health worker plus tablet equals digital health, right? But there's a lot of complexity there, from overworked community health workers to data interoperability. What does that really look like? What are the big challenges?
Yeah, thank you. I feel like I would think of that in 3 ways. And I want to commend Dr. Patrick, I think, on the vision that Kenya has really set for really a comprehensive strategy around achieving universal health coverage. And I think Dr. Patrick touched on something around a community health information system. Mm-hmm. So one component of this, when you actually think about the way that information and data has been administered in many settings over the years, has been that there has been one set of data and information, and this is in some ways attached to the pilotitis that came up earlier, that exists for community delivery of services. Mm-hmm. And then you have sort of the health management information system for the entire rest of the country that has at times stopped right at the primary health facility level. So when you actually think about the potential, and I think one of the things that it's clear that Kenya is doing and many other countries are following suit, Last Mile Health has also been participating in developing community health information systems that are actually integrated into the DHIS2, or the Health Management Information System, that many countries are actually using to make sure that you actually have a complete picture in terms of what does it look like here? How do you not make sure that you don't have siloed information? And that's important for a number of reasons. First and foremost, if you're going to be ordering commodities, you want to make sure that you're not actually excluding, in some instances, up to 40% of your populace. When you're thinking about burden of disease, when you're thinking about where you want to be able to identify and predict that there might be infectious disease outbreaks, that picture is extraordinarily important. I think the second point that I would make, and when we kind of talk about interoperability, is also that you need to make sure, and you're going to get the best data if when you design these community health information systems, if you actually design it so that it is an enabling tool to help administer health workflow for frontline providers, so it makes their job easier. You want to design, I think our humble opinion is you don't just design for data warehousing, but actually for workforce development and administration of workflow. And that will give you all of the information that you really feel like you want and that you need to manage at multiple levels of the hierarchy. And then the last element that I would sort of register around this, and that I think we've seen is really important, is that interoperability, recognizing how vitally important is to include those frontline and community-based providers, it actually needs to be connected through the continuum. We had experiences where we thought we were doing a great job of, digitally enabling a community health worker and their direct supervisor. But guess what? Like, if the officer in charge that's responsible for administering the workflow and providing supportive supervision to that nurse and to that community health worker is not actually included in that flow of information, it makes their job a lot harder. So I think at each of those levels, you really have an opportunity to think about how you're designing, making sure that that you're looking at the system comprehensively, and making sure that you're not excluding key components of either the population or the health workforce when thinking about digital system design.
I want to bring Omar into this because Leisha picked up on the point of pilotitis, and Leisha also made the good point in her initial remarks about putting the last mile first. And again, drawing on your private sector background, would you love to just hear briefly from you, coming out of COVID-19, or at least this chapter of the pandemic, what is the role of the private sector in putting the last mile first? And what's one thing you wish perhaps tech companies, the private sector, might do a little bit differently in their engagement with NGOs, in their engagement with governments?
Well, a number of things. First of all, flipping it a little bit, I think there's still a lot of mistrust, if you like, between the private sector and the government, and that the government thinks that private sector is only out there to make money. And of course, making money is important, but most private sector companies have a mission. Medtronic, for example, has a mission which doesn't start with money. It starts with using technology to alleviate pain, restore health, and extend life, which means improve outcomes through technology. And the conclusion there is that by doing that, you will make money. So money isn't out of it, but starts with the mission first. And I think building a trust level there, where we're all out there trying to help people, that improving people's lives is all of interest to us. It seems simple, but building that trust and the amount of time that sometimes we spend in just trying to convince each other that we're really trying to do the same thing. And then in that sort of period, you get stuck into negotiating and wasting time and all that kind of stuff. So I'd really encourage us to build that trust. That's one thing that I would do. The other is what I just mentioned, maybe 2 points I'll make. One is this focus on outcomes is, I think, very important. I think it's important to build the infrastructure, the digital infrastructure, but how you use it. Because in the end, like we said, every patient is different. And in fact, I'd like to take your red, green, yellow kind of sort of statement to another level. I'd like to do red, green, yellow by patient. And then the ones who are red are the ones that I spend the most time on. And I think that's the level in which I'd like to take it. So by patient and outcome orientation. are the things that I would kind of focus on. And I think the private sector has a line of sight to creating value which also has a financial impact. And I think in the end of the day, if you improve people's lives, the healthcare costs will go down, not go up. And so within governments in particular, and even in the private sector, there's a sense that healthcare just costs money. Well, if you improve someone's life, in the long run, you will save money. And I think that connection is something that maybe the private sector can work with governments in and show that, look, there's a return for this, and work on that.
Before we go to the audience for a question, I just want to quickly understand from each of you, I'm going to ask you this question in two ways. And essentially, why does this gathering, the World Health Assembly, matter when it comes to digital health, right? Like, what might happen this week to meaningfully move the needle on digital health? Or what needs to happen between this week and this time next year to move the needle on digital health? So whether it's, what needs to happen this week or what needs to happen in the next year before we all reconvene in Geneva, I would just love to quickly hear from each of you on this before we go to the audience. Maybe start with Omar?
Yeah, I think, look, this is a gathering where people from different entities get together with different backgrounds. I think get focused on the problem. And next year, if we can actually start talking about some results, that would be a good goal.
Yeah.
It doesn't have to be everything, but maybe in one disease area, show how the needle moved, how, in the area that Ruchika is working on in hypertension, and in Kenya, where we've got a big program. Did we move the needle in hypertension in a way that you can demonstrably show it?
Yeah.
And let's use next year's conference as a milestone that we can actually demonstrate it and show it to the public. So that's the kind of thing that at least I'd like.
I love that. Thank you. Dr. Patrick?
This gathering is important because it brings the entire global community galvanized towards a common cause of improving health outcomes. More so in low-income countries, which are facing huge challenges, including epidemiological transition with the increasing burden of non-communicable diseases. We will never have enough workforce, for sure, to be able to address all those challenges if you take cognizance of the fact that the communicable diseases are still there, the outbreaks, epidemics, and potential pandemics. So it is important that we support each other, move together collectively, so that we can be able to design interventions. And I believe when we gather here next year, as my colleague has said, we'll be able to demonstrate results that will be more compelling for all of us, a global community, to continue investing to improve the health of the globe.
Thank you. Jerome?
So I think we need to realize that it can be done. It saves money, and most importantly, it saves lives. And I think this is where we've got to realize that connecting the most unprivileged communities, those that actually face the biggest burden often in terms of health impact, and that's across the world, with the best technology, really brings, whether that technology is actually medicine or whether it's a tool. We're talking about, here's something that is a tool for health. It's not just a phone or a tablet. That's a medium to enable that tool. And that it can be done, and it needs investment, but it will save huge amounts of money. If we learn anything from COVID, the prevention, the ability to involve communities, the ability when you don't have the right tool, the right time, to get the right messages across, to then, when you do have the tool, get the vaccination on time, is about connection to communities, and digital health is a key to all this.
Thank you. And Leisha?
I will riff on Jerome's point on investment. So I think this convening is important because it brings power together. It brings together multilateral, bilateral, private sector stakeholders in a way where there's an opportunity to really acknowledge the social ills that we're all looking to address and to align on ways to address them. And in particular, I was looking at the Lancet Commission on Women in Health recently released a report that said that roughly $3 trillion a year is actually subsidized on the backs of women who are either paid or underpaid in healthcare roles, and the majority of them are actually women of color. That would make those women the largest financial contributor at this gathering to healthcare.
Wow.
So next year, I would like for that to not be the case. Pay them and Yeah, that's all I have to say.
That's powerful. Thank you. We do have some time to go to the audience for a couple questions. And I'll note we started a bit late, so we're going to go a bit late because it's such a critical conversation. But I want to go to Emmanuel Blin here, founder and CEO of Tech Care for All, and bring his perspective into this conversation as well as a question, and then hopefully build in time for a few more.
Thank you. So, hello, everyone. Thank you for having me here. I was asked to do two things: share an additional insight and ask a provocative question whilst you prepare for yours. So I started my company 6 years ago on two priorities: community health, how to help them with digital tools, and upskilling the workforce in Africa through digitally enabled training programs. And after 2 years of pilotitis, experiments, and all of that, on the community health, we gave up. And so we are now refocusing everything on workforce development. So I reflected on why is it that we did give up, and we did give up because we did not see any opportunities to scale, and it was 3 years ago. And I would like to offer a perspective which creates my question. So I happen to be as well the chairman of a pathology AI company in Germany. So I was thinking, why is it that digital health is picking up very fast in the West, and why is it that it's not picking up as fast as it should? Because I think you all say there is value in digitalizing community health workers. Why is it that it's not picking up fast enough? So very quickly in the West, as we all know, a big investor, a big customer of digital health innovations is the pharma industry and the medtech industry. And you don't see that happening in Africa. With a few exceptions, Medtronic being one of them, but you don't see a lot of this happening. So the big corporations, the private sector is not there, as it is in the West, to support those digital health innovations. And second, why is telehealth picking up in Europe, US, Japan, etc.? That's because it's reimbursed. I mean, telehealth consultations are paid, are reimbursed by whoever is paying, whether it's the patient in some countries, whether it's the government, private insurance companies. So I was thinking, okay, but in Africa, maybe we don't have pharma, maybe we don't have reimbursement, but we have donors. There is a lot of investment made by donors. So there is a lot of talk about we have to shift donor money to local private sector, to your point. We have to enable local innovators to thrive. And that's talk. There is a bit of action. So how do we bring more of the donor money behind the local innovators who are willing, really willing, all of them I know, are really willing to enable community health workers across Africa to work with digital tools? How do we better do that work all together as an ecosystem so that there is more investments going to the ones who are inventing good solutions, local solutions, affordable solutions for the people we absolutely need to help, who are these community health workers? So that's my question. How do we do that?
Thank you. Any reactions to that? Lisha wants to jump in, and we'll hear from others.
I really appreciate that question. I'll offer one perspective, and then I'm sure that my fellow panelists will have others. I think one thing that we've really seen, particularly within the digital health space, and particularly when we're seeing silos of interventions of technology, is that it actually all tracks back to the financing. So I would absolutely agree that there's a need and an opportunity for crowding in greater financing, particularly on the continent of Africa, particularly around community-based provision of care. Though I would also argue that there is very fragmented financing that has often been either condition or disease specific, that's coming in through different angles, in which it's actually not being considered in a more holistic and integrated way. We've been working with Global Fund and a number of other groups on a integrated financing fund called Africa Frontline First. There's a first round catalytic fund that has recently kind of been up and running with the first phase of investment of about $100 million. And the particular purpose of that financing is actually to offer more integrated opportunity for not condition-specific design of technologies or interventions, or even in some instances standalone health workers, but to actually leverage all of those platforms and the incredible talent that exists so that that financing is not actually inducing or disabling more integration of service delivery at the community level, but rather supporting and enabling it. So I think that that's one step, is to use the money that's coming in a way that is actually better and more inclusively applied.
Omar, you want to jump in?
Yeah, I just want to kind of add to that a little bit and say that, look, and I'll bring in sort of private sector perspective a little bit, because the financing, the word that has to go along with financing is return. If it's just financing and it's just a donation, you're not going to get it. There's only so much money in the world, people will look for returns. Now, returns doesn't have to be the priority. The priority has to be an improved outcome. If you have an improved outcome, you will get the return, but you cannot divorce the return from the result of what you're doing. So I'd really encourage the thinking about financing to connect to a return where your priority of how you finance will then take, and coordination of different elements will take priority. And I think that's better not only from the outcome, and it'll give you the return as well. In fact, I'd like to add to what we were just saying in the next meeting, and not only show how in Kenya we've scaled the lowering of hypertension in the community, but what kind of financial return did the healthcare system in Kenya get as a result of that. That may be more challenging, but I'd really like to ask the team to look at that, because it's financing and return. If you put the two together, you will get private sector involvement. Without that, it's a charity. And, there's sort of reluctance, let's put it that way.
Dr. Patrick, what's your reaction?
Thanks. And Africa does not require charity; we require partnerships. And if we are to go that direction, we are open. There are areas of investment, including private-public partnership, where you'll be able to invest your money. We agree over a period of time how you are going to recoup. But I think what Omar is saying is really fundamental, because if you improve the health of the people, healthy people mean good business, and good business means good returns. Therefore, what the development partners ought to do is to be able to support us, to have one plan, we have one budget, one M&E framework, then we can be able to cure the pilotitis once and for all.
Thank you, Dr. Patrick. And Jerome, before you jump in, I want to hear your reaction, but also, I mentioned earlier not only your role with BRAC, but formerly your role with MSF, and I do want to hear from you on the unique challenges and opportunities in conflict and crisis settings as well, since we haven't touched on that explicitly.
So I don't have much to add to the panel. I mean, it's not working in isolation, and I can only agree with what Patrick is saying. It's about partnerships and building not just a partnership with someone who's going to do for you, but a partnership of equals in terms of those that work on the ground, those that have the technology, those that actually have the responsibility, which is governments, and working really in a constructive partnership to actually find ways in which the investment will bring the impact, the return that we're seeking, and get to scale. Now, what we need to do to get to this is we need to showcase as well the good stories, those that have actually made a difference, and showcase them internationally, because there's a lot out there, but showcase the ones that are not just isolated, the ones that have been through these kind of partnerships. The little project that actually has achieved good success but hasn't gone to scale is not as interesting as the big ones that have gone in partnerships with governments, with the private sector, and with frontline actors that involve community health workers. Maybe on the broader side, so I left MSF over 4 years ago, but it's the same issue. It's an issue of access to information, the right information. It's an access to a good decision-making support, and it's an access to actually being able to ensure that when you're blocked to actually reach a health center, or people cannot get out of a certain environment, that you have a tool in place that can actually bridge the information. So it's not radically different to what we're talking about here. Maybe the main difference is that it's harder to get into communities because you're in a crisis setting. So access is even harder there. So instead of having to focus at the community level, quite often the focus will be at the structural level, which will be more in the primary healthcare center and or in the OT, where you can have telemedicine come into play. Yes, the issue, again, I join what's been said by the panel, is that you can't overburden and you need to make choices. So again, in crisis setting, you will prioritize what you need to do to have the biggest impact. And so it's a better priority. And so MSF first developed its decision-making tools through mobile health on pediatrics, because that was one of the most impacted age groups within crises. So you have to make those choices. Otherwise, if you try and do everything and put everything on the community health worker, then it will not work, and it will just be an overburdened and not efficient system.
I want to thank all of our panelists and return to something that was mentioned earlier. Omar mentioned this in terms of results. So I wish we had more time to dig into results so far, but I hope that in a year, our audience, both here in person and online, can take some of these really powerful calls to action to heart, and that we will see even more exciting results a year from now. You know, again, a lot of potential, but still a really big gap in terms of seeing the impact in some of these communities. So thank you for all that you all are doing on this, and I'll just note we're going to bring up a closing speaker in just a second, but for now, please join me in thanking our panelists.
Thank you.
Thank you.
And with that, I'm going to quickly welcome Ruchika Singhal, President of Medtronic Labs, back to the stage. Oh, along with Phil from the Africa CDC, who I believe is joining us as well. Back to where it all began. Please come on up. Thank you so much. So as we close out the day, at least this portion of our programming and head to lunch, would just love to hear from both of you. Any final quick reflections? I'm going to come sit next to you. I feel so far away.
Well, I think the panelists said it all. So, I mean, I think I hear this from Omar for 10 plus years, focus on results. So that's really it, you know. I think what I would say is digital is not digital for digital's sake. It's about improving outcomes for patients, and it's about improving the efficiency of healthcare delivery. There's billions of people without access to healthcare, and we have to get them good healthcare access. The way that's going to happen is through partnerships. We have to plan for scale. That's why we're both here. Plan for scale from day one, focus on results, and we come together, because I think the fragmentation, the only way that gets solved is when we act together at the local level. It's not about somebody designing outside and imposing that, but really co-designing on the ground, bottoms up. And very excited. We're on this journey together, and we've made some promising starts, and we're excited to do this together and invite really everybody to join that journey together.
Yeah, absolutely. And the way I can summarize what I heard is through three Ps. First, the people, and I think Dr. Amoth really gave a very good picture of what could happen at the community level. We most of the time forget that all this we are doing for the people, they should be part of it, and really showing them a well-analyzed picture of their data and what we are learning and how it's informing the healthcare delivery that they are receiving is a very compelling vision that I think if we can realize it in all the communities in Africa, would already have solved so many of the problems that we are talking about here, and I think we could be talking of true universal health coverage. The second P is about the profits. I think the private sector, I think the issue of trust that Omar you talked about, I think we're getting into a better place, but I have to say we haven't gotten there yet. So the conversation and dialogue that has to happen between the governments and the private sector on promoting health through technology, and perhaps technology can even be used as a catalyst to facilitate that dialogue. Having been in government for many years and looked at private-public partnerships in different sectors, I must say that in health is where it is the most difficult. In other places, infrastructure, trade, commerce, it's less tricky, but in health, it's still a bit tricky. So we need to have even a cadre of people who can understand both the language of public sector and private sector to sort of act as a bridge, and that's possible. The third P is, so I talked about people, profits, and partnerships. So partnerships, I think that's, but in the new Africa Public Health Order, we want to see respectful and win-win partnerships, because not all these partnerships are like that. It's not good partnerships when you dream and design with all good intents a solution from Geneva or Washington and come and, tries it in a community without even asking their opinion or involving them. That's not the kind of good partnership we're talking about. It has to be respectful. And again, I'm overquoting Dr. Amoth when he said Africa is not in need of charity. That can't be so true. It's so true. It's not charity because charity doesn't scale. But true partnerships with win-win propositions do scale, and that's what we are saying we are ready for.
Thank you. I want to close just by asking very quickly from the two of you, because I asked it of our panelists, and I'd love to hear their perspective. What's one thing that needs to happen between this year's WHA and next year's WHA, so that speaking of results, it's a different conversation next year? One thing, ever so briefly.
Well, my boss already told me what to do, so I'm not adding to that.
You have your work cut out for you.
Yes,
Okay.
absolutely.
I would ask everyone here to join us in what we call partner working groups. We've got 10 flagship initiatives as part of the Africa CDC digital transformation strategy, ranging from connecting all the health workforce to digitizing primary care, to scaling up innovations, to bringing the digital health community together, to applying AI for health, to increasing distributed diagnostics technologies. So join us. We've got a very tight deadline of getting to June 30th with a blueprint of what we want to do. And by the time we come here next year, we'll be telling you about the progress we've made between the potential to realizing and possibilities.
Love it. We'll dig into results. Well, thank you so much. Thank you to all of you for your time and attention. And I will close quickly by saying thank you to Medtronic Labs for supporting our journalism, both online and on stage. It's a critical topic, so thanks for your support. Thank you, everyone.